A very warm good evening to everybody who is attending FEM 2020. Our session is on a very interesting and a topic which raises a lot of queries: medicalization of subclinical hypothyroidism. And with me today are a very eminent panel of speakers, of experts in endocrinology. And I would like to introduce the speakers with me. I am Dr. Gagan Priya, myself, endocrinologist at Fortis and Ivy Hospital, Mohali. In the last few years, I've gone back into the realm of academics in terms of medical writing, as well as speaking at national, international conferences, as well as I've tried to build up a forum of ladies in medicine in our region, which is an interspecialty interaction among women physicians. And it's been a really heartening experience to see women coming to the forefront across the endocrinology and other specialties also. I do love writing poetry and dancing. And next to us is none other than Dr. Anju Virmani ma'am, who was my senior at AIMS. So she is moving cities, but she's finally found her home in Delhi. She's very proud of that city, and so am I. With my 3 years of stay in Delhi, I found that Delhi was a really good and warm, welcoming city. Dr. Anju has been a pediatrician who then trained in endocrinology, and she is the pioneer in the field because she was the first pediatric endocrinologist to set up practice in Delhi. And even today, I get patients who come proudly, who have moved cities and say, we are Dr. Anju Virmani's patients. She's a very keen advocate for neonatal screening of hypothyroidism and to improve the care of children and adolescents with type 1 diabetes. She's obsessive about not wasting food and other stuff, and also about balanced diet plans. Then we have Dr. Rajeshwari, who did her MD in medicine from PGI Chandigarh and her DM in endocrinology from SG PGI Lucknow. And she's currently a senior endocrinologist working at Columbia Asia Hospital, Bangalore, and Adarsh Nursing Home, Tumkur. She was awarded the best oral paper presentation in Australia 2002 during the Asia Pacific Pediatric Endocrine Society. Her special areas of interest include diabetes and vitamin D, calcific pancreatitis, as well as pure electrolyte imbalances in intensive care, an area I think we as endocrinologists often fail to address. She's an active member of the Endocrine Society of India, of RSSTI, and the Adolescent and Pediatric Endocrine Chapter of India. Then we have Dr. Anjana Bhan, who is one of the warmest human beings you'll come across. She did her graduation from Lady Hardinge Medical College and then moved to US. She completed her PG in internal medicine and then her fellowship in endocrinology and diabetes from George Washington University Hospital, Washington. And she was formerly at Indraprasth Apollo Hospital. Now she's a senior consultant endocrinologist at Max Hospital, Delhi. She loves to travel, enjoys music, and spends quality time at NGOs that help cancer patients. So with this very eminent panel, I would request Dr. Anju Virmani to please give us some opening into what this concept of medicalization of subclinical hypothyroidism is.
Thank you very much, Gagan, for that very kind introduction to all of us, and good to catch up with Rajeshwari and with It's good that we can only catch up in this way, but it's better than nothing. So let's get to the topic itself. And subclinical hypothyroidism is a very vexed topic with a lot of opinions. I think there are endocrinologists. The definition is fairly straightforward. It's an abnormal serum TSH. Thank you very much, Gagan, for that very kind introduction. And let's get to the topic, which is a fairly vexed one. The definition of subclinical hypothyroidism is fairly clear. It's a situation where you have abnormal serum TSH with a normal T4, whether we take a free T4 or a total T4. And it is fairly common condition. Now, hypothyroidism itself is supposed to be about 1 to 2% of the normal population, of the general population. And subclinical hypothyroidism is maybe somewhere between 5 to 20%, depending on what population one is looking at. The 5% figure is supported by a relatively recent paper. This was published in February 2020 before COVID took over the whole world. And this was a paper from the Birmingham Elderly Thyroid Study, which said that in 19 general practices in UK, the percentage was 5% in the elderly. They had made the point in that paper that there was no difference in the symptoms of euthyroid and subclinically hypothyroid individuals. So we come back to this very vexed thing about what is the problem, what do the patients face, what does the doctor decide about. Opposed to this 5% figure is what the Colorado Thyroid Prevalence Study said in 2000, which was that as many as 22% of ladies above 60 years have subclinical hypothyroidism. Now, one of the things that happens is that the prevalence of hypothyroidism does increase with age, but so does the reference range for TSH. So does that rise with range. So Leng and Rizvi in February 19 in a review in thyroid research brought out a lot of evidence, including an RCT by the Trust Study Group in NEJM in 2017, which said that the treatment of subclinical hypothyroidism may not benefit the quality of life or the symptomatology of older people, and in fact could potentially do harm. And this was in spite of the fact that the trust group had taken a cutoff of 20, not even 10, which is what we conventionally do, and said that the elderly perhaps don't need much care. One also worries about the possibility of medicalization. After all, once you're labeled as hypothyroid, mere ko thyroid aa gaya. And that excuses everything. If I have poor memory, I don't even want to try and remember things. I'm obese. I don't even want to try and slim down. Mere ko thyroid aa gaya. And everything gets blamed on that. And we do need to be worried about that. Of course, there is a lot of data which suggests that there may be comorbid conditions. So, for example, a very local, very close to home study from Action Balaji Hospital, they showed a very high incidence of dyslipidemia up to 100% in antibody positive hypothyroidism. So maybe we want to look at those things and not treat the hypothyroidism so-called itself. And then let me approach this like Benjamin Button and go backwards. So when you get younger women, particularly those who are planning a pregnancy, and I'm sure we'll be discussing this in great detail much later, a woman who's at risk of pregnancy or planning a pregnancy, then we want detection pre-pregnancy because the cutoffs are very different, and the 2019 Thyroid Association guidelines were very clear. The TSH should be below 4 if antibody negative and below 2.5 if antibody positive. So this is a very different kettle of fish. And it can be very frightening because Dr. Bhan's recent publication in PLOS ONE in June 2020 showed that in 2,000 non-pregnant women in Sangam Vihar and Dakshin Puri in Delhi, these were lower middle class and middle class families, as many as 13% of the women who were planning a pregnancy were hypothyroid. That's huge. And to muddle this whole thing up is the effect of obesity on TSH. 15% of obese individuals have a high TSH. Are we looking at obesity causing a TSH rise or the TSH causing a problem? It gets very messy, and I'm hoping that Gagan Priya and everybody else will help solve some of these problems. Now, if we go further back in time, then children are again somewhat like the elderly, that they perhaps don't need so much replacement. But with children, we have the great joy that the growth itself is like a bioassay. So if the child is tall and fat, as opposed to what a hypothyroid child should be, a hypothyroid child should not be growing well. And if the obese child is tall, it's much more likely to be a non-significant clinical problem. So here, things are very different. And then we go further back in time, and in the newborn, the TSH makes a big difference, and we'll be discussing that later. So I think with the emphasis that we should be screening every single newborn with the TSH in the cord blood, I'd go back to Gagan Priya for further questions.
Thank you, Dr. Anju. The wonderful insights, and I think we can have a wonderful discussion built on what you've laid the foundation stone for. So, Dr. Rajeshwari, like Dr. Anju was mentioning, the TSH cutoffs are getting revised, after every few years. I remember when the TSH cutoff came to 4 or 4.2 as the normal, there was a huge debate going on that if we start using this, 1/4 of the population might become, labeled with a disease. And I mean, are we really using subclinical hypothyroidism as a disease diagnosis? What are the precautions when you see an abnormal TSH report? Do you label subclinical hypo straight away, or is something called transient TSH elevation?
When we take for any values, not just thyroid, anything in the population. So when we take everyone's values and put it as a curve, you will get what we call as a bell-shaped curve. Okay, so those people who are within the 95% of that curve will be considered as normal. Both the sides 2.5% will be considered abnormal. That is how the normal values are usually proposed. So for that, so when what happens is, whether the 2.5% slightly, there is something called skewing to the right or left based on whichever the parameter we are checking. So that way we check, that is one way of looking at normal values. But when we say normal population, we don't know. When something called subclinical is there, who is normal, who is not normal. It's very difficult to prove that. So now we look at the symptoms. So whether the patient has symptoms or not. When they have overt symptoms, we call overt, symptomatic, we call overt hypothyroidism. As we already defined, TSH, which is high, and a low free T4 or T4 is called overt. However, even in the overt also, there are sometimes very high TSH, body compensates, and T4 is still normal. We often see such a situation. And T3 most of the time is, of course, normal. So even whatever the TSH may be. So still, this we call as overt. Whereas subclinical, where most of the time the symptoms are not there. By definition, subclinical. So it's only the lab tests that are abnormal. So what is the cutoff? When we treat any disease, we should know that there is some benefit in it and a little bit of risk. So when the risk is this much and the benefit is this much, definitely it is worth treating it. But when we look at the TSH, when it's very high, 100 or something, gradually we bring down. So when it comes towards the lower down, you see the risk, and the risk is almost equal to benefit. That is the time I think we should stop treating it. This is what it should be, at least in such disease situations where the risk and benefit is not going to be very different, or risk is more than the benefit. Then I think that is the point we should take. So roughly, when we look at the TSH, they have taken a value of 10. Beyond 10, definitely we have to treat, because what they have found is for many parameters, including cardiovascular, and Madam already spoke about cholesterol levels, they do improve with treatment of the thyroid itself. So, and quality of life is much better. That's much more proven when it is beyond 10, especially when it is beyond 20. Below that, it has not been proven to be so beneficial. So this is one thing. And you talked about the transientness. Yes, a lot of time, one single thyroid levels changes throughout the day. More likely to be higher in the morning compared to the evening, and with age. As Dr. Anju Virmani already told, younger age children, the levels are newborns, it's very high, and then it gradually comes down. In toddlers, and middle adolescent age, it reaches the adult level, and then again in elderly it goes up. So based on the age, and we have to decide. Other thing very commonly seen, someone is very obese, everyone says you should get your TSH done. They tend to get some fever, some whatever, they go that, why not check the thyroid at that time? So the levels are abnormal. So it may not be in fact high, it may be somewhat low. To follow it up, they'll repeat after 1 or 2 weeks. That will be higher. So this is one thing very, very commonly we see in clinical practice. When the TSH is higher after illness, when you're recovering from illness, it's higher. So it's a transient one. So after 2-3 months, you wait and see, it would have normalized. So any acute illness, very severe illness needing ICU admission or acute fever, these are the times the thyroid can fluctuate. In fact, during recovery, it goes very high in the subclinical hypothyroid range. And if you wait, it can come back to normal. So this transient one we should realize. So subclinical hypothyroidism by definition, TSH high, but T4 should be normal. 1. 2, you have to repeat after a period of time like 3 months roughly, usually which we do as 3 months. If it is high, then probably we can confirm as subclinical hypothyroidism.
So excellent points. I think for our general public who will be listening to this, I would just like to summarize what we've discussed so far, that the kind of borderline TSH elevations when we see, they don't always come with symptoms. In fact, that diagnosis is more of a lab diagnosis, and it is for the clinician, the endocrinologist or thyroid specialist to assess which are the patients who are at risk. And the risks include, the risk of heart disease, the risk of cholesterol or lipid problems. And then there are special categories such as women planning a pregnancy or those who are pregnant, where the risk is higher and treatment would really benefit. In the other cases, I think we have to assess this on an individual case-to-case basis. And a large majority of these individuals, I won't even call them patients, they don't really need medication. And medication really won't help. We'd be unnecessarily putting somebody on a lifelong medication. So I think that's the carry-home message from Dr. Anju and Dr. Rajeshwari so far. So Dr. Anjana, with your experience, a lot of patients come to our clinics, and they must be coming to you also, and they're saying, this borderline, they come with a 7 TSH value, T4 is normal. And the complaint is my weight gain has happened because the TSH rose, or I'm having mood disorders because of this, I'm feeling stressed out, or sometimes it's general body aches, and all these complaints are put on that TSH. Do you think there is really a correlation of these symptoms with subclinical hypothyroidism?
You've described a very typical, I think 50% of my patients come with the same complaints that you said, and I think all of us see that every day. More often in women, I think. It's true that thyroid has, or hypothyroid really has very non-specific kind of symptoms. If somebody has a pneumonia, they'll have cough and sputum or fever and things like that. Of course, cough and shortness of breath can occur in a heart failure patient also. So that's where the clinical acumen comes in, and then you steer towards labs and diagnostic modalities. All symptoms of hypothyroid are so non-specific, starting with I'm always feeling cold, I had gain of weight, aches and pains, my mood is low, hair is falling, thinning of hair, dry skin, constipation, irritability. And when people are coming out enumerating, when patient is sitting in front of me, I think I can probably say more than 80% of what she said is what I am undergoing also, all of us. I feel like saying, I have that too. But on a more serious note, these symptoms are very non-specific. But I think your first, when you started the whole discussion, was about medicalization. And that's maybe that's what comes in here. A behavior or set of symptoms have got a diagnosis, a medical diagnosis, and we are aware of these medical diagnoses. That's how we treat and we monitor and all of that. So sometimes it works to our benefit, like obesity is now a disease. It's not just that you're a glutton or you don't exercise, and many things like that. Arthritis symptoms where always people had crooked arms, crooked hands and stuff like that. Finally, the diagnosis was made. I think fibromyalgia, many of these such kind of diseases, and hypothyroid, I think, is a real condition. It is a real problem. So as I was saying, they're very non-specific. So how do I choose? Now, in the real world, as most of us work in metro cities and all that, many times people come to me with the thyroid labs already, referred by the dermatologist for hair thinning. And mind you, that's a very tricky place because all of them are on biotin and they never tell you they are on these medications. So you've got to be very carefully watching their labs and checking on all of that, those histories. But they come from dermatologists, they come from gynecologists who for irregular cycles or infertility and such like that. So a lot of my patients are referred from other places with the thyroid labs already. They've also gone to the extent of doing ultrasounds and stuff like that. But that's another story. So if somebody, and many of them also have, where I work at Max Healthcare, and I think at most hospitals, they have health packages. So even a 20-year-old and others get DEXA scans for that matter, because it's in the package, it's all included. Thyroid is included. FT3, FT4, TSH is a routine in all of these health packages. And so they come with labs, they come with symptoms, they've talked to their relatives, their friends, their colleagues and all that. And as Anju said, mujhe to thyroid ho gaya. High hai ya low, we don't know, That's what finally when you look at the report. So how do I choose? If somebody comes brand new to me and says, I've heard that there is such thing as a low thyroid or a high thyroid thing, then I start with history taking, start with family history. Do you have, because we know it runs in families. It's more common in women, but with history taking. So what, you go over all that gamut of hypo kind of symptoms of weight gain and all of that sort of thing. Then have you had infertility? If you've been trying for a pregnancy, have you had miscarriages? Have you had any kind of radiation to the head and neck or face or something? So many of those small questions. History taking is a very big thing. And then if you say no, these are very non-specific kind of thing. I think one should, as Dr. Rajeshwari said, benefit versus risk is a very important thing in medicine. Guidelines do tell us things, but we can tailor those guidelines to our patients. For instance, the ATA says don't do universal screening in all pregnant women. I don't believe in that. I think the Indian guidelines say check TSH at first antenatal visit, So we look at the guidelines, but then you can tailor it to your own patient. So I often, if people are giving me these non-specific, which sound very true, this person has gone from patient to patient, from doctor to doctor, from dermatologist to gynecologist to rheumatologist, I think she deserves or he deserves the TSH rather, and a T4. And oftentimes, again, the labs do the whole gamut of all the three. And then you take a call, So history taking, if there's a slight goiter also, a little enlarged examination for that matter. If there's a slightly enlarged neck here, swelling, no ultrasound is needed. Just do the labs first, And it's not a hugely expensive test. It can be done most of the times. Better to do it in the morning because, as Dr. Rajeshwari said, the levels TSH can come down. If you're seeing an OPD patient at 3 o'clock, I wouldn't. I'll say go and do it tomorrow. So tomorrow morning, and that kind of. So tailor your thing, you'll get the right report. And history taking and examination is very important. Plus the use of other medications, many medicines. Many times, elderly patients will not even tell you that they are on amiodarone because they think that is under the realm of a cardiologist. And you're not supposed to. I'm sure all of us face this, they'll never tell you about the other medicines. So these points are important, I think.
Yeah. Wonderful suggestions. I think I always tell my, whenever I'm given a report to interpret, I always tell people that I don't treat lab reports, I treat people. So we have to look at the full clinical context, the history, the examination, the risk factor evaluation, and then consider the lab report in its clinical context. And as we learned from Dr. Rajeshwari, and you also mentioned biotin, we have to also look at the pitfalls which could have given a wrong report, reconfirm anything that comes as erratic. So that takes me to Dr. Anju. You had mentioned about, in children, borderline TSH values come in, and then there's something called neonatal or congenital hypothyroidism. So what is your take? How significant is this problem? Should we screen every newborn for hypothyroidism? And should we blame the borderline 7 TSH for childhood obesity?
Okay. So, Gagan Priya, I would like to go back a little bit to what Rajeshwari said and reiterate the changes that happen when the cord is cut. There is immediately after that, there is a thyroid surge. And the TSH shoots up in about a few minutes to about a couple of hours, goes to a maximum of anywhere between 10 to 20, and then slowly starts drifting down. Because the TSH surges up, the T4 goes up. hits a peak in the first day of life and then slowly drifts down. So by the fourth or fifth day, the TSHs come down to about 10. And then between the age of 5 or 6 days of life and about 3 months of life, the TSH can normally be about 9. And some people just take 10 as a cutoff, as a rounding off. After the age of 3 months, one should have adult values. So it's not that the TSH drifts down over a period of time. It is up to 10 weeks or 12 weeks that you would take a TSH of 9 or 10 and not beyond that. So if you were to look at the newborn, I think it's absolutely crucial that if we don't take any other message from this meeting, if we can just have one major thing in big font, bold, underlined in red or whatever, saying that every single newborn, no matter what the mother's thyroid status is, no matter what the family status is, every single newborn deserves newborn screening for TSH. And the easiest thing to do it is in the cord. Filter paper sounds very good, but it's very difficult to do. Lots of logistical issues. The cord has to be cut in any case. There's no extra prick, there's no extra effort. As more and more deliveries get institutional, I think it's important that every single newborn needs to have a TSH. And now why is that? The reason is that the baby who's born with congenital hypothyroidism looks absolutely normal. 95% of them have no clinical signs or symptoms. You can take as high a risk of index of suspicion and you would still miss most of them. And yet, by the time the baby symptoms come up, by the 3rd or 4th month of life, the baby is permanently mentally retarded. So here the risk of doing harm is actually missing a diagnosis, and every single baby should have a TSH. Of course, as Rajeshwari said, and I reiterate that the cutoff is 20 at birth. In the first day of life, if you were to miss the cord blood and do it just before discharge, it could even be as much as 30 or 35. And the T4 tends to be on the higher side. So if the TSH is more than that, then we quickly reconfirm with the venous sample and try and start treatment as early as possible. And I think the proudest moment of my life was when we had this baby delivered at 9 o'clock in the morning. The TSH report came by 2 o'clock. It was 496. We got a scan done the next morning and we had started treatment for this lingual thyroid by 2 o'clock the next day. So before the baby was even 36 hours, she had a diagnosis, she had a treatment, she was on her way to being absolutely normal. If the baby is seen for the first time by somebody and the cord screening was not done, it makes sense to do a TSH at that time. And the cutoff would be 9 or 10. If it is more than 9 or 10, please get worried and start replacement. But once the baby is more than 3 years old and brain development is over, then one is in a very different scenario. So if I was to have a baby come, as Anjana said, they're carrying their thyroid reports with them, they got a whole bunch, maybe they were 2 or 3 thyroid reports with them, they've also confirmed it from another lab and then from another lab. And they've got this TSH which is 8 in one lab, 6 in the other lab, and they'll say, dekho kitna farak pad gaya, it has dropped or increased or whatever, and it's all within the same below 10 with a normal T4. I would look at the entire family. What is the mid-parental height? What is the child's height? Is the child tall for his or her mid-parental height and age? And then I would make my decision, because if the baby is tall, the child is tall, then it's very unlikely to be hypothyroidism. Again, let me be not categorical about this, because patients constantly take us by surprise, and I've had a tall child who was in early puberty, and so her height was not affected yet, with a TSH of 80. So I needed to start her. But that's not what we're talking about today. Today we're talking about a TSH less than 10 in an obese child. Knowing that obesity itself can raise a TSH, I would just follow up this child very carefully and not actually start treatment, because again, you don't want to medicalize obesity. The moment you say that you've got a thyroid problem, they will continue eating as much, they'll continue not playing. Obesity may be a disease, but it does have a huge lifestyle component, and they will stop paying attention to that as soon as the thyroid medication is started, and then come back to you 6 months later saying, "Par weight to kam nahi hua, they haven't improved," because, and that was not where the problem was. So we need to be extremely worried about starting thyroxine in a child who is growing well, already tall maybe, and just has a borderline TSH with a normal.
So I think, yes, good points here. So Dr. Rajeshwari, we'll move from one end of the spectrum, the children, to elderly. I mean, we've understood that there are variations in TSH that happen across the lifespan. We do see a lot of elderly people coming with routine lab reports, and this is something I call the package syndrome. They do a package and they find an abnormal thyroid report and they come to you and they insist that TSH of 7 should be treated at this age. So what is your take about subclinical hypothyroidism in elderly?
A very well brought out point. I've had patients who wanted an emergency consult. There was no appointment. They said, what is the problem? TSH is 5.5. I didn't know whether it was low. They had thinking, is it high? And what's the age? 75. Okay, then don't even bother. That's what I would say. Leave alone the emergency appointment. This is the amount of medicalization that has happened. Actually, that is the most important. I want to point out here. And as I already told you that as the age increases, the TSH natural, like physiologically, what we call normally goes up. Up to even 7 considered is fine. Some studies even show the higher the TSH, longevity is more also. To that extent, it is somewhat good. So, beyond 75, if the TSH is a clinical hypothyroid range, that is between 4 or 3, whatever cutoffs we take, to 10, even if you don't treat, they don't have any benefit even if you treat. So rather, they can have higher risks of the treatment itself. So beyond 75, I don't think we have to worry, unless of course T4 is less and TSH is very high and such things, and symptomatic. That's a totally different category. So elderly, they do tend to have a higher TSH, and the cutoffs are not like the younger adults. We should know that. And usually the labs give, some of the labs do give according to age. So that's very important that we have to tell them. And beyond 10, if they have symptoms or if they have a gland that is swollen, definitely these are patients have to be treated, even in elderly. But we should be cautious about the doses. I think we can discuss about it. And if it is something like, below 10, the range of 7 to 9, nothing, no hurry. If the T4 is normal, no hurry. After 3 months, call them back. There is some, apart from the TSS, there is one more thing called the antibodies, TPO antibodies. So that is one more thing that can guide. Very high levels of antibody suggest that these patients may go into a overt hypothyroidism. So this is one more thing. On follow-up, we can ask them. No hurry also for that. So TSH, repeat it after 3 months, add an antibody levels. If the gland is not enlarged, so antibodies will also predict whether they can go into overt hypothyroidism. And there are some patients who insist, these are the symptoms. Sometimes the symptoms also are mimic, like they have in hypothyroid. So you're not very sure. Clinical, when you see examine, they look fine. But some of the symptoms are like that, so you're not sure. Because when we see a 7, over the lifespan, I would say in the population, the TSH normal may vary. For an individual, it doesn't vary a lot. If you see in different, I've seen patients in different times, they have done the TSH. It's very closely in that range. Someone is 3, over 10 years, 50, 20 years, and all that, around 3, they remain. Suddenly, if it has jumped to 7, at that point, when it is 7, we won't know whether what is the normal for that individual is. So that is important. So someone is 3 and has gone to 7. Someone is always around 6 and 7. I've seen that. They remain that way forever. I've seen after, they have shown old records of, they have 2 decades old, and they bring and show, and it is in the same range. Nothing has changed. T4 has been normal. They have been normal. So for that individual, we are not sure whether that was high unless we have a previous report. So if it is something like that, we can try and give a trial of treatment. Around 9 it has been. Patient has some symptoms. We'll try. We'll make it very clear. It is trial of treatment. Write it there, because it should not be lifelong. If someone has to be branded lifelong, no, we should be 100% sure whether the diagnosis is correct, even if it's for a simple thing like hypothyroid, subclinical hypothyroid. So may say, these are the symptoms I'll list. When you come back, I'll go through each of them. Has it been corrected or not? If it is not corrected, then this trial was useless, so we stop it. You don't benefit from the treatment. I think we make it clear, and that is the only situation we can start. Give a trial of 3 to 6 months. Useful, we can continue. But when we start the treatment for subclinical, we should be very careful. There are 3 aspects. One is the level of TSH, age of the person. And these are the things we can take into account and start with the weight of the patient. If the patient obese, they need, according to the weight, the dosage also varies. So based on this, we can give a trial and see, even in the elderly, but should be very, very cautious for this age group while treating. Because there is, as I said, when there is a benefit, there can be risk also. What are the benefits? Probably we are looking at the elderly. The cardiovascular diseases are higher with age. So that is, and we know with a higher TSH, including the subclinical, some cholesterol abnormalities can happen. Some mild sugar abnormalities can happen. Whether by treating with the thyroid medicine, these are corrected, and that reduces the cardiac risk. That is what probably people are looking. That is one thing. Other thing is, many of the symptoms are mood changes, depression, and such things, which is more of quality of life. So these two, if we are going to correct, these are the benefits we are looking for, these two benefits. Other side, when we look, there will be risks of treatment. What are the risks? Usually, if you treat them with to reach a level of T4, which is TSH, which is in the range, middle of the range, the risks are usually less. But a lot of times it happens, we may overstep or over-treat. That is when. So in the elderly, I will be worried of two major things. One, again, coming back to cardiovascular. Usually, the thyroid, when you give replacement, it increases the metabolism in general of the whole body. So the heart rate would increase. Sometimes it will be so uncomfortable that tachycardia, faster heart rate, palpitations is what they feel. Sometimes it can be irregular also. Either very fast rate or irregular heart rate, both can be detriment to the heart pumping itself. That's very important. So they are pushing for a small benefit, we should not push them into a major cardiac risk. The other thing is osteoporosis, the bone, thinning of the bones, or especially so in women. Elderly, we are talking about women. With over-treatment, the risk of bone loss is also higher. So we may be, if they are already osteoporotic, then it can worsen it more. Or elderly in general, they are prone for it, you can induce the osteoporosis. So unnecessarily, we should not treat them. One. Two, when you choose to treat, you monitor to keep the level or keep the dose at the smallest level so that they get only benefit, not the side effects. I think these two are very important.
Excellent points. I think moving from these two special populations, you'll also come to the most important population when it comes to subclinical hypothyroidism. So Dr. Anjana Bhan, we do see a lot of pregnant women now coming with thyroid reports, and some of them have had a previous history of miscarriage or are dealing with fertility issues. So I think subclinical hypo is the most significant issue that in this context of patients. So what is your take on how to approach these women, let's say before they plan a pregnancy and then during pregnancy? Ma'am, you muted. Yes.
So I think every female in the reproductive age group who is your patient, or if your patient knows another person who is, or that should be a general awareness in the population, is that a woman in the reproductive age group, and if she's planning pregnancy, should make sure that she has a thyroid function test done before planning pregnancy and be seen by a gynecologist or an endocrinologist. Now, there's another group of women who already are hypothyroid and they are taking their replacements over the years and all of that. So even those people should know specifically, categorically, that they should maintain the TSH value of ideally less than 2.5. I mean, even lower than that is okay, but 2.5 at least before planning a pregnancy. So it's not like suddenly, it's by accident it's happened and I didn't take my thyroid medicine for a month. I ran out of the pills. And that's the general story that we generally come across, So those are two categories. One, a lady who had hypothyroid should maintain a TSH less than 2.5 at least before planning. And any other simple person who has no history of thyroid is, if they're planning pregnancy, at least check it prior to the actual decision. And another category here is the people who have infertility or who are going for an ART assisted reproductive kind of methodology, IVF, ICSI, and all of those. They definitely need to have TFTs done before they start on that course. So those are three. Now, there are people who come to you who say that they're 8 weeks pregnant, or just, the pregnancy test at home was positive and they've come to you, and what should they do now? So again, history taking and all of that, history of infertility, history of miscarriages, multiple births, family history, history of polycystic ovary syndrome. PCOS is also known to is associated with higher TSHs also. All of that should be taken into account. And then, so you check on that. Now, if someone has pre-pregnancy, or actually when they come, as I said, 6 weeks or 8 weeks of gestation, and unfortunately, I think all international guidelines have changed so much over the last few years. They have confused us as specialists. Forget the patients. I think they've confused the gynecology. And then there are differences from the gynae guidelines and the endocrinology different guidelines, the international, even within America, between the American Thyroid Association and the AACE. And then last year we had our own TSH set, I think it was in the Indian Journal of Endocrinology, where the settings were given also. So there have been so much of debate and changes, and it's not really not so. It should be probably, because our population is different all across the globe. Iodine levels are different. Some are iodine deficient populations, some are fairly all right, some are well replaced. Then all these tests and labs that have set up TSH targets, those studies have been done at different times of a pregnancy. Some at 6 weeks, some at 16 weeks. Replacement has been given at different times of their gestations. So there have been so many variations. But I think what most of us are following now is probably the 2017 ATA guidelines and the Indian guidelines, which was published last year for our population reference range of TSH. And here, what we know is that, I think just about 6-7 years ago only, the target TSH's upper range were 2.5, 3, and 3. And to date, most of the labs in Delhi give the same range. At the end of where the thyroid function reports are given, at the end they give trimester specific, it's still 2.5, 3, and 3. In India, I think it was found that our TSH levels we should not go by 4, they are a little low, and probably 3 and 3.5, 3.5 in the first, second, and third trimesters. Although 4 is not a bad, if you go by that, you're not being hugely wrong also. So, where were we to start with? So anyway, so if a person has come with a TSH at 6 weeks or 8 weeks, I hope early enough at the first antenatal visit, with a TSH of say less than 2.5, and it's very suppressed going down to 0.1 and all of that, then that's different. That's a whole new different story of hyperthyroid over there. But if it's between the lower range, which has come down in pregnancy to 0.5, below the lower layer reference range, to about 2.5, then I'm not that bothered. But there's a little caveat. If by chance somebody has done her antibodies, which happens often, it happened once with my patient, an antibody was also done along with the TFTs, and the TSH was only about 2.5 or 2.4, something like that. And the gynecologist had sent her to me to start the medicine. So only antibodies with a normal population reference range of TSH, you need not start her on medication, but you should check her every month, and just like your routine other patients. So that's a different story again. There are lots of ifs and buts in the hypothyroid pregnancy arena. So anyway, so now if they're over 2.5 to 4, for instance, which I'll take as the upper limit of reference range, or 3, but let's take it as 4 by the ATA guidelines. If they're or everybody over 2.5, blanketly do a TPO, do a thyroid peroxidase antibody. Again, lab will do both sometimes also, but TPO is what has been recommended. So if it's between 2.5 and say 4, then, and TPO is positive, there is a weak recommendation to start levothyroxine. especially in people who've had miscarriages or pregnancy losses and multiple thing, or they're over 30 years and those kind of things. If it is 4 and above, 10, over 10, of course, again, eyes closed, you can start. 4 to 10 with TPO positive, also start. Now, many times you do this and your TPO comes negative. So if the TPO is negative between 2.5 and 4, not necessary to start. But again, I think individualize over there. If your patient has had these many multiple pregnancy loss or things like that, early premature delivery also before 37 weeks or an IUGR, then the benefit is more than the risk. So you start and you monitor. It's very easy to monitor, and you get them to a target of 2.5 TSH. So that's in negative. But if they are TPO negative and they are, you know, uh, over 10, over 10, there is no question, you just go ahead and start. I think so. This little range, and these are in the guidelines very specifically, it's very easy to follow. So that should not be. And I think it's better that the endocrinologist kind of takes over here and monitors. And in monitoring also, monitoring is very important, because as Dr. Rajeshwari is saying, in elderly, you can go the other way around. So monitoring 4 weeks initially, every 4 weeks, and then after 26 or 20 or 26 week to the end, you can do it once. I sometimes do it twice. I am more paranoid. I do it a little bit more. And once they deliver, if this was a lady who was already taking, with a past history of hypothyroid, then you can decrease it to the pre-pregnancy dose and then check again at 6 weeks, 3 months and onwards. Now, if this was a lady who you started in pregnancy and her requirement is somewhere near 50 only, you can stop it cold turkey after delivery and then check again at 6 weeks. Somebody who's on maybe 88, maybe you can reduce it to half of it and then check again at 6 weeks and 3 months and all of that. And one more thing which goes with the pregnancy thing is, it's very safe in breastfeeding and lactation. So you should continue. In fact, if the person becomes hypothyroid by just stopping the medicine, then they can have poor lactation. I mean, poor breast milk production and all of that. So that's very important, and it's very safe even after delivery.
Yeah, so I think those are very relevant and important points. So I think we've had a wonderful panel discussion. I'll just put some key pointers of for everybody to summarize what we've discussed. First, I think, like Dr. Anju Virmani pointed out, that thyroid is not a disease. It's a normal gland that is an important functioning endocrine organ that regulates multiple functions. So it can either underfunction, which we call as hypothyroidism, or there might be other overfunctioning in other diseases. So when we're looking at hypothyroidism, there are different, gradations of disease. It's not an all or none disease. So there are those who have actually marked clinical hypothyroidism, something we call as overt hypo. And for most of our patients, when TSH is above 10, and especially if T4 is low, they fit in the category of overt hypo, and treatment definitely brings benefits. So there's no debate on that. But for the category of patients where TSH is, let's say, borderline between 5 to 10, we are looking at a lot of factors. What are the biggest concerns in this category, which is subclinical hypothyroidism? One, will they progress to overt disease later on? So that's, I think, we've discussed the risk factors. If the antibody is positive, the risk is more. If they have other, past history of radiation, or they're on drugs like amiodarone, or there is a goiter in the neck, a swelling in the neck. So those are people who might progress. We have to look at those factors. And the second category, risk, why we are worried about subclinical is, what will it do to the risk of long-term diseases? So cardiovascular disease, of dyslipidemia, will it contribute to obesity? Does it contribute to mood disorders and all? I think for that, we have to have an individualized risk factor-based approach, assess the person in totality. And the other very special category, which Dr. Anjana Bhan highlighted, was the women who are planning pregnancy or who have already conceived and they have subclinical hypo. In them, the risks are deemed to be more than the, of the subclinical hypo, and treatment in a large majority definitely benefits. It may not be permanent if the borderline TSH elevations are there. I think Dr. Anju also highlighted very emphatically that every newborn needs a screening for hypothyroidism, because we can, reduce the burden of mental retardation or poor neuropsychological outcomes in children by a simple test of TSH, either done in the cord blood at birth itself, possibly the simplest form of diagnosis, or then done through a filter paper at beyond 48 hours. So I think this was a wonderful discussion. So Dr. Anju, any final words of wisdom for our people here? Ma'am, you muted, please.
I hope my voice will be clear because I think I'm breaking up. But one thing I would emphasize, which has been emerging repeatedly, is that
Ma'am, your voice is again going on this. I
Take
think,
off this.
yeah, with that it was better.
let me try like this. So I think what needs to be emphasized is that we've been doing personalized medicine in endocrinology for the last many decades. We don't do per kilogram body weight. Fortunately, we don't have to worry about things like antibiotic doses. So we've always started with a particular dose, but very quickly got the feedback to tell us whether we're on the right track or not. And if the TSH dips too low, we know we can pull back on the dose. And if the TSH is still high, we can increase the dose. So it's important to do monitoring, as both Rajeshwari and Anjana emphasized, that we do a 6 weeks or a 3 month later TSH. We don't just start a patient on a dose and say, ab lifelong khana hai, just disappear and never come back. It's important to keep a track of the TSH and then to treat accordingly, so that you're really doing whatever is necessary for the patient rather than what the textbook says or what the body weight says.
I think one more point I think we should emphasize, when we start treatment for overt hypothyroid or subclinical for a reproductive age lady, we should always say, don't stop this medicine once you get pregnant. A lot of times, every medicine, they blanket statement, they'll stop it. Thyroid tablet is one thing which you should continue, and in fact a higher dose. So you tell them when you get pregnant, please continue the medicine and consult your doctor immediately, because it may be high. So I think this point is very important.
Yeah, I think that's an excellent point that's been brought up. We need to educate people about thyroid health particularly, but also, educate them about not medicalizing every odd TSH report which is normal. So I think we've had a wonderful panel discussion with all our experts. Thank you so much, Dr. Anju Virmani ma'am, Dr. Rajeshwari ma'am, and Dr. Anjana Bhan ma'am. It's been a pleasure to have you on board. Thank you.